Okay, welcome everybody to the our webinar for acid control drugs. And today we are going to review few things that definitely are going to be important for NCLEX. All right, so if there is, I'm going to leave still open the microphone. The noise I think is mild. So actually, if somebody suggests something, I will change it. Okay, so let me see. Somebody else came in. I want to be sure that is linked. Leslie. Okay, Leslie, can you hear me?
Watching. No, don't watching you drive.
All right, so I'm going to mute everybody. Leslie, can you hear me? Okay, so let's start. Okay, so today we will talk about the GI medication. Uh, we are going to go over some topics that are really relevant and important for the NCLEX. First of all, let's go 5 minutes about the review of what the pathology where we are going to talk. So today is the GI medication. And to talk about GI medication, we need to talk about a little bit about GERD. So yeah, you can see there. We are going to talk about gastritis and PUD. PUD. So what is in common for all these three guys? And that's going to increase the gastric acid, right? The chlorhydric acid. So what I want is you to differentiate, first of all, what is GERD and what is gastritis and what is PUD. GERD is the gastroesophageal reflux disease. And what is happening here is, the lining of the esophagus is different from the stomach. The pH of the esophagus can stand only a pH of 7. That is the pH of the esophagus. And the stomach is going to have a pH of 1 to 2. So anything that is going to go to the esophagus is going to make probably an ulcer. So when we are talking about GERD, we are talking about esophageal, the esophagus. That is different from gastritis. What is gastritis? Gastritis is going to be the inflammation, all the inflammation of the lining of the stomach. So the lining of the stomach are going to be inflamed. That's why it's called gastritis. And this gastritis can lead into PUD. PUD is the peptic ulcer disease. So as you can tell, this is about 3 millimeters thickness, and that can actually perforate very easily, and that can produce bleeding. Okay? All right, so for this, what is the purpose of this lecture? To know how to decrease this gastric acid. So we are going to talk about three things. First of all, you need to categorize all these problems of gastritis. Gastritis can produce nausea, can produce vomiting. Why produce nausea and vomiting in the gastritis? Why? Because the stomach is innervated by the vagus nerve. And these vagus nerve are going to stimulate the nausea and vomiting. So that's why when you have inflammation of the stomach, of any reason, gastritis, they are going to produce this sensation of nausea and vomiting. And of course, we call the heartburn or pyrosis. So we are going to see that there's three different groups of medications that we are going to talk for mild signs and symptoms, for moderate signs and symptoms, and for severe signs and symptoms. So we are going to see that mostly the mild signs and symptoms are going to be used antacids. Second, for moderate, you know that in medicine we go from the less invasive, the less simple medication to the most complex medication. So antacids is number one, and we are going to see the side effects. That is the main thing of this lecture. Moderate, we are going to do the H2 blockers. H2 blockers. Okay. So please just remember is the complete name is H2 blockers. Okay, it's not that HA2, H2. And severe, we are going to use the PPI. PPI. Okay, so we have the PPI, the proton pump inhibitors that are going to secrete hydrogen into the stomach. All right. So now, what is the difference between them? Antacids are going to be the fastest acting. Okay. If you want a fast act, that is going to be used antacids. For example, amphogel, that is, for example, hydroxy aluminum. Okay, fast acting. So let me see. Okay, so I know fast acting. Then we have, that is going to take about 20 to 30 minutes. 20 to 30 minutes is going to last the effect of this medication. Then we have the H2 blockers, and the H2 blockers are going to be about 12 hours duration. They are going to last 12 hours. Meantime, the PPI is going to last 24 hours. 24 hours. 24 hours. So PPI are the most effective, and the one who lasts longer. Okay? So for this, you will see that the PPI, oh, one thing I want to tell you is this. When you're talking about gastritis, it's important to know that they can lead into PUD, the peptic ulcer disease. All right, so mostly of the patients that are going to be in the hospital, about 99% of them are going to actually use the PPI. It's what we call the to prevent ulcers of stress ulcers. So that is what is the majority of patients you're going to see in your, especially post-operatory patients. And you need to remember, for example, one situation, pancreatitis. Pancreatitis is MPO. MPO, that means not anything per mouth, and not even water. So, so what is the route that you're going to use? So you need to use medication that are going to be parenteral, right? Okay, so that is about that, and for this, we are going to do the review of our lecture today. So I'm going to cut the camera, and you don't need to see me now, and I'm going to go into the screen. Okay, so here we already talked about the first three slides. So what is the composition of the stomach, what cells we have. So let's go directly to the point, what is really relevant. Just to remember, actually, this is going to be the antacids, right? It's called antacids, actually. And that is what is the main action is the neutralization. It's going to neutralize. So that are the neutralization. Then we have the anti-H2 and the PPI. So you can tell right now what is the difference between PPI and anti-H2. They are going to decrease the gastric acid, but the duration of time is longer in the PPI. So they can last about 24 hours, and this guy is going to be about 12 hours. Antacids are going to last about 20, 30 minutes. So then we have the prostaglandin that is actually to prevent, and that is a they're going to make effect in about 1 to 2 weeks. And the prostaglandin, what it's going to do is to increase the thickness of the mucus. Then we have the prokinetic, so the coating agents first, and the coating agent first are the ones who make cover of that is one of the things that can produce a rebound effect, because mostly they have calcium. When they have calcium, it's in the form of carbonate calcium. Carbonate is alkaline. So once is the medium, so that's associated with calcium. So when you take it, the calcium then is being absorbed, okay, and that is going to decrease the effect of these coating agents very fast. So that is going to produce more gastric acid at the end. So that is what we call the rebound effect. And then we have the prokinetics. The prokinetics is going to be the metoclopramide that is going to accelerate the evacuation of the food from the stomach. Okay, so let's keep going. If there is some questions, please, I'm checking the question label on the screen. Okay, so just get familiar with the names. We are going to review a little bit here. Antacids, we have, I will put it here. Let me see. All right. Here, the most common are going to be the aluminum hydroxide. Aluminum hydroxide. That is actually, then we have the carbonate, calcium carbonate, that is antacid, okay, and the sodium bicarbonate. Those three are very high yield for NCLEX. Amphogyl, but you don't, they are not going to put you amphogyl, but they put the hydroxide aluminum. So somebody is coming, just a moment, I'm going to open who's, okay, Anna, thank you for coming. All right, so we have anti-H2. David was actually having some mnemonic here that he was remarking. Is tidine is anti-H2. So ranitidine, cimetidine, famotidine. The first one who appears in the market was the cimetidine. Ranitidine appears second, and the last one it was the famotidine. So what are actually the one who produced more side effects? The one who was created first, because they have not so good pharmacokinetic and pharmacodynamics that the ones who've been produced after the cimetidine. So cimetidine is something that in NCLEX are going to focus, and that is related to anti-H2, okay? Ranitidine, cimetidine, and famotidine. Then we have the PPI, and the PPI we have all the prazols, omeprazole is the famous Prilosec, lansoprazole, Prevacid, okay? So we have Protonix, pantoprazole. So if you can see, we have three medications that are mostly the most commonly used and the most commonly asked in NCLEX. So we have the aluminum hydroxide, calcium bicarbonate, and the sodium bicarbonate. And we are going to see the nursing considerations, the anti-H2 and the PPI. Then we have the coating agents, that is the sucralfate. That this guy is the one who can lead into rebound effect. Prostaglandins, that is the misoprostol that is used as abortive, and that is going to take effect in about 1 to 2 weeks. So obviously you start taking one of these three main medications, and then you're going to start as maintenance of the treatment with a prostaglandins. And prokinetic is mostly used as to evacuate, is a regulator of the gastric intestinal motility. It's a regulator of the gastrointestinal motility. So that means that it's going to accelerate the evacuation of the food from the stomach, and that means that the gastric acid is not needed anymore to be produced. So that's why that is going to help to reduce the acidity in the stomach. Okay, so one thing, please, open eyes, open ears. The prokinetics is stimulate the peristalsis and empty the stomach content. Okay, all right, so let's keep going. And this is very important part of the class. So please, we are going to talk about the side effects that are actually high yield for exams, midterms, etc. So side effects. One thing is that in general, we need to avoid smoking. So that is going to increase the gastric acidity and is going to counteract. So it's going to be the opposite effect as antacids. So antacids, what is the mechanism of action? It's going to be the it's going to neutralize the acidity. Okay, so one thing that we need to remember is that if you take another medication, any other medication, Could be for diabetes, for hypertension, could be for lipids, etc., or anticoagulants, etc. Actually, you need to remember that these antacids are going to diminish the absorption of this medication if you take it at the same time, right? So it's logical that if you want to take these other medications, you need to take it about 1 hour before antacids or 2 hours after antacids. So you don't want to have any contact with antacids because the absorption of the other medication is going to actually be low. So take first the other medications and after 1 hour before meals or 2 hours after meals. So that is the thing that we need to remember. Always take the first the medication and after uh, the uh, uh, the antacids. Okay, so very important, aluminum. Aluminum is the amphogel, is the hydroxy aluminum. Aluminum is the aluminum who produce constipation, constipation. Okay. Magnesium. Magnesium is another element that can lead into diarrhea. The excess of magnesium leads into diarrhea. You already know that the magnesium can be toxic if you have kidney failure. So that's why they said don't give it antacids in kidney failure, especially for magnesium. The kidney normally can excrete the magnesium, but when you have kidney failure, that means 60% of the kidney is not working, the magnesium is going to stay in the blood and can produce intoxication. What is the result of this? Magnesium is going to be a depressor. So all your reflexes, all your activity are going to slow down. So the antidote for magnesium is going to be the calcium gluconate, calcium gluconate, okay? Calcium gluconate. All right, so we have another calcium carbonate here that is produce a rebound effect. Calcium carbonate is the one who is alkaline, so that is going to neutralize the acid, but when the calcium is being reabsorbed, carbonate is not going to be as effective, so the stomach starts to produce more acid. One important thing about calcium carbonate is that they can lead into kidney stones. So if you have kidney stones, you don't want more calcium. So that is going to lead into more formation of these stones, kidney stones. Bicarbonate. Bicarbonate, another thing that we need to remark, and please take note about this, metabolic alkalosis. Bicarbonate. Sodium bicarbonate is the baking soda you have at home. So sodium bicarbonate is alkaline, very alkaline. So if you have ingestion of more sodium bicarbonate, what is going to produce is alkalosis. The lungs are not involved, so actually what we call this is a metabolic alkalosis. Okay, so another remarkable thing here that we need to remember. Now, we pass from neutralization of gastric acid, let's go to the decrease of the anti-H2, decrease of the acid. Anti-H2 and PPI. Just to refresh you, anti-H2 is going to last about 12 hours. Meantime, the PPI can last about 24 hours. And the PPI is mostly what we are going to see in the hospitals with patients, especially with the post-operative. Okay? And preoperative too. All right, so we have anti-H2. The main thing that we need to remember is the thing I mentioned in class. So we have H1 and H2. H1, nothing to do with the stomach. H1 is the one who releases histamine when you're sneezing. These H2 that are causing from H1, H2 are located in the GI tract, especially in the stomach. This H2, what is going to is when it's inflamed, for example, chocolate, spices, or something really irritant in the stomach, they are going to produce H2, stimulate the H2 through the gastrin, another hormone. And that produces increase of the production of gastric acid. So Antihistaminics, for example, H1, produce drowsiness and dizziness. So this is his cousin. So they are going to have similar side effects. Okay. So dizziness and drowsiness. So if you can notice, the anti-H2 do not have drowsiness here in the the PPI do not produce drowsiness. If that is the case, it's not as remarkable as the anti-H2. So drowsiness is very characteristic of anti-H2 medication. PPI is mostly what we have is dizziness, headache, diarrhea, so nauseous and vomiting. So the three B's, the three bigs, so the nausea, vomiting, diarrhea. So those are mostly what happen in PPI. But anti-H2, remember drowsiness. So what is the nursing consideration here? Is that you are not going to give to a patient who has to do some physical activity or need to make some manipulation of machinery, because that is going to be dangerous. Another high yield for NCLEX is about the anti-H2 is that we have they are going to decrease the absorption of the antifungals, especially the azoles. What are the azoles? Azoles are going to be, for example, the ketoconazole, miconazole, etc. So those are going to decrease the absorption of this medication. So if you take antifungals and you take anti-H2, the antifungals will not absorb properly. Okay. All right. So here we have this the PPI, and the PPI, we already talked about that, prevent stress ulcers. So please pay attention to that. So when we are going to see that, a patient who is in a hospital, a patient in the hospital is under stress all the time, and that can lead into the increase of gastric acid. And in the long-term side effects, of the PPI is actually the osteoporosis. So we have the three medications that mostly are being used in the practice, and high yield mostly in the NCLEX. So those are the three ones, but that doesn't mean that the rest are not going to be asked. So that's why we are going to talk what is probably high yield for NCLEX in this case. Coating agent, we have the sucralfate, is constipation. Who else produce constipation? It's going to be the aluminum, antacid aluminum. So constipation can produce the sucralfate or can lead or the aluminum, the hydroxide aluminum, the amphogyl. We have the prostaglandins, the misoprostol, that is going to start making effect for 1 to 2 weeks. And meantime, you don't want to wait 1 to 2 weeks. You're going to use according if you have a mild, moderate, or you have a severe gastric acid. You're going to use antacids, mild. You're going to use anti-H2 is moderate. If you're going to use severe, when it's PPI. So that is the steps that when you go to the OTC, antacids is what you find mostly. Then you see more something more complicated, that more elaborate is the anti-H2, and the PPI is going to be actually the best and the most effective medication to decrease gastric acid. All right, so let's keep going. All right, so here we have some summary of what I found here. We are going to, for example, here sodium bicarbonate. If you take too much, you're going to have metabolic alkalosis. Constipation, aluminum and sucralfate. This is the coating, and this is the antacid. And they are going to do diarrhea, for example, PPI, nausea, vomiting, diarrhea, PPI, and magnesium. High yield, please, high yield. Okay, so we have calcium bicarbonate that is going to produce the rebound effect. And there is some different absorption of medication that we are not going to talk. We are not going to ask that because are coming in the next lectures. The timing is going to be the timing is going to be 1 hour before to take the medication. Any other medication is going to be 1 hour before or 2 hours after to take any of these antacids or anti-H2 or PPI, okay, or the coating, etc. All right, so that is about these antacids. So let's keep going. All right, so simeticon. Simeticon, there is another high yield. We are going to see that the simeticon is used to reduce the discomfort of gastric or intestinal gas. So flatulence, too much gas, too much distension can produce actually a painful abdomen. So what they are doing, this simeticon, is the gas are going to make it in small bubbles of gas that are going to be easy to expel from upper GI tract and the lower GI tract. Okay. So results in decrease of gas pain and increased expulsion via mouth or the rectum. All right. Patient education. So you need to, first of all, you need to stop eating spices or some irritants. And by sure, you need to stop, or the patient need to stop taking alcohol because one of the situation is this. Imagine yourself having a patient, having a medication, and the patient is coming to you, and please open eyes, open ears. You medicate the medication. The patient is telling you, you know what? I'm taking the medication exactly what the prescription is telling me, but it's not making effect. So this medication is not good for me. So what you need to do? You need to investigate you need first of all to know the factors that can make the gastritis still in progress, and that is actually the meals, if it eats too much fat, or the coffee, especially smoking. Okay, let's pass to another topic. Limit the use of NSAIDs. What is doing the NSAIDs? NSAIDs is the ibuprofen, for example, most commonly known as Advil. We have the naproxen, okay? We have, but remember, acetaminophen is not an NSAID. Acetaminophen is not an NSAID, okay? So that's why they are going to change into acetaminophen if that is the case. So what is doing the NSAIDs is going to cut the cascade of the prostaglandins who produce more mucus in the stomach. So the NSAIDs are going to decrease the thickening of the mucus. So that can lead into ulcers. All right, so that is about that. So let's keep going to our next high yield topic. So here we have, and I will go to the, let me see if I have my picture. No, I don't have it. Okay, so it's, something is missing here. Anyhow. All right, so here we are going to see what is diarrhea. First of all, in general, you need to check what are the habits of the patient. The patient, they go 1 or 2 times a day, 1 or 2 times every 2 days, 3 days, or whatever. So that is your baseline. After that, you can compare is that if the number of the bowel movements, BMs, increase, and you need to know that there is an increase of fluid inside. So you can do diarrhea, so it's a normal number of bowel movement plus the increase of fluid inside on the stools, okay, in the stools. All right, so acute diarrhea, 3 days to 2 weeks. Chronic is lasts for more than 3 to 4 weeks. All right, so let's keep going. And here we have the anti-diarrheal. We already talked that we have three groups that we are going to discuss. It's the adsorbent. You know what is the difference between absorbent with B as in boy with adsorbent. So that is different. So here we can have the bismuth subsalicylate. Bismuth subsalicylate is the pepto-bismol. And what is important to know here is the salicylate. Salicylate is family of the acetyl salicylic acid that is the aspirin. This is aspirin. So they are going to be aspirin here. So this aspirin anti-diarrheal actually can, if the patient is taking aspirin for another reason, that can be an overuse or over increase of the dose. So you need to be careful about the bismuth subsalicylate. That is the typical use for traveler's diarrhea. Careful with Ray's syndrome. Ray's syndrome is caused encephalitis in children. If children has a virus like influenza or special influenza virus, if you have fever and the only thing you have aspirin and you give aspirin, that can produce encephalitis. So that is a contraindication to give a Pepto-Bismol to a patient who has a viral infection fever. All right, so we one thing that is high yield for NCLEX is the bismuth subsalicylate are going to dark stools and blue gums. Okay, I remember you mentioned in the classroom. All right, so let's keep going. So here we have, so remember absorption, right? It's like absorption is what is going to, is not absorption, right? Absorption will be is not. Absorption is like the substance is going to be like a magnet that is going to retain substance into, is going to retain the retain the content in the GI tract. Antimotility is important because remember we was talking about giant cat. So we are going to use anticholinergics. So cholinergic, you remember the giant cat is produce contraction of the smooth muscle, and we are going to use in this case anticholinergic because diarrhea produce increase of the peristalsis, and anticholinergic is going to do the opposite. So that is going to decrease the peristalsis and going to decrease the diarrhea process. Give me a second. Somebody turn off the lights. Just a moment, please. Oh, okay. All right, so that's good. Okay, and we have the opioids. So the opioid derivatives, and very high yield, please. So we have antimotility. We have two types, anticholinergics and opioids, right? So one of the side effects, by the way, of anticholinergic is going to be dry mouth, high yield, dry mouth, anticholinergic. All right, so, okay, let me see if I open a little bit, just a moment. I'm going to open the, okay, so I cannot, oh, okay, just a moment. Anna, can you hear me?
Yeah.
Thank you. David, can you hear me?
I can hear you.
Okay, perfect. All right, so any question, just let me know, please. Hopefully you can see the video as we didn't see the last time. Okay, so opioids, we have the main side effect is going to be respiratory depression. We need to remember that it's going to produce to constipation. So what you need to remember for this time is the loperamide, Imodium, is the opioid derivative. These do not cause dependence, even though that is opioid. This opioid is not going to actually be absorbable as easy as the other ones. So they are going to produce less. Do not cause dependence. Do not cause dependence. Okay. Then the probiotics. So we have the absorption. We have the antimotility for the areas, and we have the probiotics. Probiotics is to mostly is the lactobacillus. Lactobacillus this is bacteria that is going to replenish the flora. When we are going to use that, for example, if you have diarrhea for because you have C. diff. You was taking medication in the hospital, and these antibiotics sweep out the flora, the normal flora. So and when that happened, the one who mostly survive is going to be the C. diff, because C. diff, if you remember, is going to have sporulation. So they're going to cover itself with a capsule when the antibiotic is coming. So when the environment is more benign for these bacteria, they open the capsule and start to reproduce. And that produce inflammation and produce diarrhea. So probiotics, what it's going to do is to make to proliferate lactobacillus organisms that are going to compete with the Clostridium difficile. All right, so that is about diarrhea. Constipation, okay? So the difference between what is a chronic constipation, the causes of constipation. So one thing I want to, what we use for constipation, we are going to use laxative, okay, laxative. One thing I want to tell you about laxative is that the laxative, if you use or abuse of laxative, that is you are going to become dependent. So there is many people outside that are going to be taking laxative for the rest of their life. So that means that the patient was abusing this medication and they become dependent. One more thing I want to tell you. Constipation is you cannot poo, right? So they are going to produce some laxative. They are going to get rid of the fecal material. But when somebody is abusing this, in addition, you are losing potassium. You're losing potassium. You're losing potassium. So that is how you can explain these people can have some arrhythmias, So that is actually part of the clinical history, and you can actually detect. That is a very tuned, very fine investigation about laxative and arrhythmias, for example. So few people don't think about that. Many people don't think about that. Cautious use of laxative is recommended in presence of this acute surgical abdomen, appendicitis, and abdominal pain. So when you have, especially, please, if you have somebody who abdominal pain and fever, if probably you don't know is that infection is coming from the GI tract. If you are going to produce, if the patient is constipated and you are going to try to lose some laxative, what is doing the laxative is to increase the tonicity of the contraction of the intestine, and that can lead into perforation, okay? So in that case, it's contraindicated. So abdominal pain, fever, don't do any, not enemas, no laxative, because that is, so in that case, what we do is mostly hydration of the patient, and then we can do another measurement later if that is necessary. All right, so laxative, we have here stimulants and osmotics. Stimulants and osmotics. We have the Dulcolax, is the bisacodyl. We have stimulants. What they're doing is, remember I was saying, if I bother somebody, you're going to react, right? So the same thing is with the stimulant. The stimulant is going to irritate, is going to bother the mucus of the intestine, and what is doing the intestine get upset and start to contract faster. So that is going to stimulate the peristalsis and the evacuation of the substance, of the fecal material. Osmotic. What is osmotic? Osmotic, please, one thing that is you need to must know is the polyethyl glycol. So that osmotic, what is doing? So remember bioscience, the universal law of concentration, right? So everything needs to be in balance. the higher concentration, they need to decrease the concentration in order to make even everything. So this polyethylene glycol is a substance that cannot be absorbed by the mucus of the intestine. So they stay in the lumen of the intestine. So inside the lumen of the intestine, we have high concentration of this glycol, that is a carbohydrate, and they are going to, what is going to happen? So inside the lumen, high concentration of this, outside of the lumen, low concentration of that. So what is doing the body, because these molecules cannot pass, is going to bring water into the lumen in order to dissolve, in order to try to equal concentration from inside and outside. And that is going to produce increase of volume of water in the intestine, and that's why it's called osmotic, and that can produce the facilitate the evacuation. Lactulose, another high yield lactulose. Lactulose is used when you have, for example, some hepatoencephalopathy. When somebody have hepatitis, they can actually not the liver cannot change the ammonia into urea. So these urea mostly of the time are 50% reabsorbed. For some pathophysiology we are going to explain another time. That is normal. So what is doing the lactulose? The lactulose is going to hold or absorb the urea, and the urea is going to be eliminated. If you decrease the amount of urea in the body, probably the patient is going to improve his LOC, because too much urea in blood in blood can lead into LOC. So lactulose, what is going to do is produce this diarrhea, but actually making absorption of the urea, and that is going to be eliminated. So it's a double purpose actually. All right, so let's keep going. So we have the stool softeners or bulk forming. We have the stool softeners, and we have the bulk forming laxative. For example, when you are going to use stool softeners, you're going to use stool softeners when the patient is having some medication that probably is going to make him constipated. For example, if the patient is in hospice and taking morphine, opioid. So most likely this patient, you need to make comfortable these patients. And for that, you're going to anticipate the constipation situation. And what you're going to do is to give some stool softeners, for example. We have the bulk forming laxative. It's very big mistake that if you take bulk forming, like especially the metamucil that is full fiber, you need to take with full glass of water. Because if you don't do that, you are going to make it worse. Because what is doing the fiber cannot be absorbed, high concentration in the lumen of the intestine that is going to bring water inside the lumen. So that is how the fiber is going to be forming the stools. Now, if you take this PO and you don't take enough water, what you're going to do is make it worse, because everything is going to be dry, and that is going to produce more obstruction. Okay, so I think the connection is lost. I have a, okay, I'm going to, just a moment. I'm sorry, just a moment. I'm going to open somebody. All right, so can you hear? Hello? Okay. side effect is going to be the decreased absorption of the fat-soluble vitamins, the fat-soluble vitamins. So everything that is in gel here in yellow, that is really important, really high yield for NCLEX, for NCLEX. Then we have the polyethyl glycol, okay? So that is going to be, they are going to be used when you have, for example, a colonoscopy, okay? A colonoscopy, they are going to just clean or evacuate that is hyperosmotic. It's a lot of fluid coming into the intestine. Lactulose, they are going to be used also for reduce elevate serum of ammonia. And we are going to probably talk this in the review that we have on Thursday. All right, so magnesium hydroxide, that is an antacid that is, is for, is used to, for example, laxative, magnesium hydroxide that is going to produce, remember the side effect of magnesium? So this is medication that is antacid, right? But they produce immediately relief of the burn, but they can be used as a laxative because magnesium can lead into diarrhea. So we are using this side effect as a benefit in this case. Magnesium citrate is the fastest laxative, so it's immediate relief. Everything that is magnesium is very fast. And we have here the Dulcolax, the bicyclodeal. All right, so let's keep going. Let me see if I have something. Oh, okay. So, okay, I'm going to go to the main thing here. All right. So I hope everybody's listening. If not, please let me know. Okay, so I can hear some voices there. Okay, so I don't know what happened with the computer. All right, so here we have nausea and vomiting, and that is all high yields. Okay, open eyes, open ears. We have the scopolamine. What is the scopolamine? Anticholinergic. Anticholinergic. Remember we was talking about cholinergic that pee, poo, and all fluids, right? Spit, pee, and poo. So everything is going to be out from the body. That is cholinergic. Scopolamine is anticholinergic. So if you create a lot of saliva with cholinergic, the anticholinergic produce dry mouth. And that is going to bring some nursing considerations like oral care. Okay, so one thing that is important to know that the scopolamine is used as a patches. And you need to educate the patient that these patches are going to last for 3 days. For 3 days. Another thing that is important, we are going to talk about the anti-H1 that is for nausea and vomiting. So if you can review the graphic I draw with the brain and all that, so those antihistamine H1 can lead into nausea and vomiting. So we are using antihistaminic. It's not only for allergies, in this case for nausea and vomiting. What is important to remember, always write down 10 times if you want, please, if you can, the hydroxyzine. Hydroxyzine. Hydroxyzine, marking here, hydroxyzine. So that is, they don't have IV. IV. So that is high yield for NCLEX. You know why? Because there is medical errors commonly here happening in hydroxyzine. If they ask you the hydroxyzine to give it by IV, you need to question the order. H1 side effects, drowsiness. Then we have the antidopaminergic that are going to be dropaperidol, mostly they produce pseudo-Parkinsonism. You know, dopa is going to tune the activity of your muscles. If you have anti-dopa, you're going to start having shaking arms, shaking muscles. The metoclopramide is the prokinetic. Prokinetic is used to as the GERD for gastritis or GERD. But metoclopramide can be used for nausea and vomiting too. So what is going to do? The main side effect is the pseudoparkinsonism. Another thing that you need to be aware is the prokinamide. Prokinamide. Prokinamide is, for example, the lidocaine. Lidocaine is the local anesthesia. Or, for example, the lidocaine used for antiarrhythmics. Lidocaine is used as an antiarrhythmic. So if that is allergic to this, so you cannot give the metoclopramide. Okay, so let's finish this, and we have the neurokinin receptor is a serotonin blocker, aprepitant and fosfaprepitant, and that is another one who can lead into constipation. Remember, this medication is for nausea and vomiting. And the star of all these guys are going to be the Sofran, the Ondansetron. Ondansetron is the most common used for nausea in chemotherapy. So listen, if somebody is receiving chemotherapy, that is going to lead into nausea and vomiting. So we need to prepare the patient. How soon? How early? At least half an hour before they take the chemotherapy. Okay, side effects are going to be the diarrhea. So just remember, the most common medication of Ondansetron for patients who are receiving medication chemotherapy. Dronabinol is the marinol. The marinol is derived from the marijuana. And actually, when any other medication for nausea and vomiting are failing, are failing.
Manga?
Does everybody hear him?
Yeah.
I don't hear him anymore.
Oh, no, I can hear Dr. G. I can hear somebody in the background.
Yeah, I hear other people, but I can't hear him, and he's not looking at the questions.
I don't even know where the questions are.
Does anybody else hear him?
Oh, I can see him.
I can see him, but he's not.
I can't
I
hear
can't
you.
hear you. No, I still can't hear him.
Dr. G, no. I think he doesn't know we can't hear him.
I think he knows we can't hear him, but he's not. I don't know.
I don't think he knows we can't hear him.
No, I don't think so.
Oh, we can't hear you, Dr. G.
Yeah, see, he's talking about it.
Yeah.
Unmuted.
Can you hear me now?
Yeah.
Yeah.
Tell me,
Yeah.
you hear me the lecture or no?
No.
None?
No, it just
Only
went out
some of
for
it.
like 5 minutes.
Yeah.
Oh, the last 5 minutes?
Yeah. And maybe like it came back and then it left again.
Okay, so do you hear about
Right
this?
there.
Do you hear about this?
Only,
Half of it.
yeah,
Most
half
of
of
them?
it.
Half of that. Okay, so let's repeat it for everybody, okay? Okay, so this is important, please. So do you want me, the speaker, tell me, please, or somebody tell me, do you want me to start from here or previous one? Because I want to be sure that we have the review. Hello?
I think that's fine.
Okay. All right, so please, this is very important about hydroxyzine is antihistaminic. So that can produce drowsiness. But what is important about this hydroxyzine is that there is no IV presentation. There is no IV presentation. So if you have an order with hydroxyzine and they tell you IV, you need to question the order because they are hydroxyzine is a very useful medication and for nauseous and vomiting, but they are not in IV presentation. So only the rest are PO, IM, IV, but hydroxyzine do not have IV presentation. All right, so then we have the antidopaminergics. So those are dopamine is going to give you the tune of the movement of your muscles. So if you have anti-dopaminergic, you start to have shaking, and that is called the pseudo-Parkinsonism. We have the metoclopramide. The metoclopramide, as you can remember, is a prokinetic, correct? And this prokinetic is used for GERD or gastritis. So this metoclopramide can be used too as antiemetic. This antiemetic can actually we need to remember that they have prokinamide. Prokinamide can have serious allergic reactions. For example, if the patient is allergic to lidocaine, lidocaine is a topical anesthesia for minor surgeries on the skin, and the lidocaine can be used too as antiarrhythmic. So if they are allergic to those medications, you cannot give the Reglan or metoclopramide. Then we have the oops. Okay, then we have the neurokinin, the receptor antagonist that ends in pitant, diarrhea, can lead to diarrhea or constipation. We have the star of all this group is going to be the ondansetron. Please, this is very important. Ondansetron. Ondansetron is the most common use for nausea in chemotherapy. So patients who are receiving chemotherapy, they need to be pre-medicated. With what? With ondansetron. How early? About half an hour. And they can be used to as in the post-operatory. So that is very important. Please. Then we have the derivatives from the marijuana, that is the marinol, is the dronabinol, that is going to be used only when the previous antiemetics anti-nauseous antiemetics are not working. So the choice after this is going to be the marinol. They can be used too as a stimulant of appetite. Okay. All right, so one thing here, antiemetics, and this is the last part, is about ginger. Ginger is used as an antiemetic. So, for example, okay, all right. If you, for example, have your ginger between your hands and you do this and smell it, that is going to produce an antiemetic effect. So ginger, some cultures, they eat it, they put it in the food, and you need to be careful because there is an incident about ginger that can produce uterine contraction and abortions. Okay? All right, so that is about, I hope that you could hear me or see me, and I hope that you like the webinar. Hopefully it was helping. So I will see you guys on Thursday. Thursday, yes. Thursday, what time? At what time?
Profit too.
Huh?
In the morning or afternoon?
In the afternoon. It's going to be, oh, okay, no, Thursday. Thursday is going to be our reviews. At what time? 4 to 5, I guess. At what time until you finish your course or your lectures on Thursday?
At 2.
At 2 o'clock. Please, if you don't have any other activity, we can do review on Thursday. So I will be here. About what? About the same thing. So I want to really be prepared. We are going to ask more questions. Now you have already 2 times the lecture. So I think that help you a little bit for your midterm or for final and for your next test. All right. Thank you so much. I need to thank you, everybody. Thank you. I will say thank you, Hemi. Thank you, Maria. Thank you, Anna. Thank you, Arisbeth. Thank you, Depika. Thank you, Cassandra, Leslie, Monica, Solimar. Thank you so much. David, he left. And Jasmine is not, I don't see her anymore. And Joanne, I didn't see her neither. Anyhow, thank you so much, everybody. I will see you tomorrow. Thursday, sorry.
Thank you, Dr. G.
Thank you, Dr. G.
Thank you. Thank you. Bye-bye.
Thank you.
Bye.